Hi again, everybody. This is the second video of our pre-class lecture series before our academic half day on this Thursday, April 16. So this part is going to be about puberty. So I'm going to be going over basic principles and also some of the disease that we'll cover during the lecture. Again, it's going to be a little bonus for someone who's watching this video. As I mentioned earlier, we're going to have an online version of endocrine quiz. And if you are watching this video, I'm going to be giving you some clues of the question that's going to be asked for the quiz. So let's start by going over principles of endocrinology. The second and a third year resident may have seen this before. I use it every year when we do our academic half day, because this is the principles of endocrinology that if you understand, you're going to be able to use this knowledge to dissect every endocrine disease. So hypothalamus and pituitary has a central role in controlling hormone secretion. So hypothalamus releasing hormones, right? If you remember, anything that ends with releasing hormone is from hypothalamus. Growth hormone releasing hormone, gonadotropin releasing hormones, or thyrotropin releasing hormones are all from hypothalamus. So the releasing hormones stimulate pituitary gland to secrete stimulating hormones. So anything that ends with stimulating hormones, such as thyrotropin stimulating hormone, or TSH, is pituitary. FSH, which is follicular stimulating hormone, is pituitary. Luteinizing hormone, LH, is also pituitary. So once stimulating hormones are secreted, it binds to the endocrine gland, whatever that thing is, thyroid, gonads, adrenals, and stimulate the endocrine gland to secrete hormones, right? So when we talk about thyroid hormone, for example, thyroxine is the thyroid hormones, testosterone and estradiol are sex hormones, or cortisol, right? So these hormones will bind to the target organ receptor. And when it binds, it also has a feedback loop to pituitary or hypothalamus. So these completes the loop of the control of the hormone secretion. So when we talk about endocrinologic diseases, we often pay attention to whether the cause is coming from hypothalamus or pituitary. We call this together as a central cause, or the actual problem coming from the endocrine gland, right? This is often called the primary cause. So we're going to apply this principle to our puberty. So puberty, again, the central unit, hypothalamus, secretes gonadotropin releasing hormone, GnRH. So GnRH stimulate pituitary gland to secrete FSH and LH, and FSH and LH binds to the gonads, so testes or ovaries, and stimulate the gonads to secrete testosterone or estradiol. So once testosterone or estradiol binds to the target organ, it also sends a feedback loop to pituitary and hypothalamus. Again, it doesn't send the feedback loop to gonads. In testes, there's no androgen receptor. In ovaries, there's no estrogen receptor. So it sends this feedback signal to pituitary or hypothalamus. So this is the control loop of the puberty. We call this hypothalamic pituitary gonadal axis, or HPG axis. So again, when we talked about physiologic control, we need to understand the timing. As you recall, children has to go through puberty, right? So, and each stage of puberty um, corresponded to how much sex hormones are being produced from the gonad. So remember, this is very similar to a growth pattern that I mentioned in the first video, that at each stage of childhood, you have differences in terms of the HPG axis and also the amount of hormone. So this HPG axis is very active in utero. Why? Because sex hormone is required for sex determination or formation of external genitalia. So the HPG axis is very active in utero, right? And after birth, there's a surge of gonadotropin, and it goes down within 2 days of life, right? So as you recall, when we have cases that we suspected ambiguous genitalia, we try to obtain sex steroid within 2 days of life, because after that, the amount in the serum disappear very quickly, right? So the HPG axis becomes inactivate very rapidly after birth, right? And it enters the quiescent period in childhood, right? So you have very low amount of gonadotropin, GnRH releases in childhood. So for whatever reason that we know some of it, it's a very complex mechanism of the gatekeeper, right? It's a neurologic signal that triggers the release of GnRH, right? So the hallmark of the activation of HPG axis is the release of GnRH. And now we know there are different proteins that are involved. One of the most important protein is called kisspeptin. So I'm going to be asking you in the quiz, kisspeptin, and you might want to look that up. Why it is called kisspeptin? There's a reason behind it. But now we know that the kisspeptin is the one that triggers the firing of GnRH neuron to secrete GnRH. And remember, if you remember from physiology, the GnRH neurons secretes GnRH in pulsatile, right? So it has a peak and has a trough. The peak is often higher at night, right? So that's why when we obtain sex steroids, we do it in early morning, because after the GnRH release at night, you have the highest amount of sex steroids in the morning, right? So it's after this GnRH neurons start to produce GnRH, right, in pulsatile fashion, right? So your gonads start producing sex steroids, right? And this is the representation of the activity of HPG axis, right? So the more advanced in your puberty, the higher the amplitude, the higher the amount of sex steroids is being produced, right? And then it plateau, right? Meaning that it's become stable, right? So when you obtain serum testosterone in adult male, it's pretty stable, right? The phenomenon of pulsatile secretion, or the fluctuation of amount of estrogen, still persists in women, right? So we do estradiol level, it depends on which part of the cycle you're obtaining, either follicular phase or the luteal phase, right? We're not gonna cover that in this lecture. We're gonna be focusing on this part, the childhood and during the pubertal development, right? So this looks very, very similar to the growth pattern, right? So you have a very steady rate of growth during childhood. Once you start making sex steroids, right, you accelerate growth, right? And then during mid-puberty, this is when you grow the fastest. This is why in the first lecture I said we're gonna put these two together, right? Once you can put these two together, it will start becoming easily to understand for you why growth spurt occur during mid-puberty, right? Because of the amount of sex steroids that is being secreted. right? So when we talk about disordered of puberty, we have to understand the normal timing of puberty. We don't understand the normal timing, we can't tell whether patient has pubertal problems or not. So remember, we talk about statistics, right? So in girls, the average is about 10 to 12 years. And in boys, it's about 12 to 13 years. This is um, this is referring to the first signs of puberty, right? First signs of secondary sexual characteristics. And we have a standard deviation of 1 year, right? So remember the statistics, right? 5% to 95%. So what is considered early, right? So it's average minus 2SD, right? So for girls, 10 minus 2 times 1, right, equals 8 years, right? So that's why we said girl who has secondary sexual characteristic before 8 years is considered having a precocious puberty. In boys, it's 12 minus 2, right? It's 10 years. There's some slight variations right now in terms of the definition of precocious puberty, but for the simplicity, we're just going to go with 8 years in girls and boys 10 years. Some say 8.5, 10.5. I think it's just a matter of just 6 months. So we'll go by something that's going to make our lives a little easier. 10 years or 8 years or 10 years, right? Now, delay puberty, right? So you don't develop any secondary sexual characteristics plus 2 SD of the average time. So that's why the definition of delayed puberty is 12 plus 2, it's 14 years. In boys, there's still some argument going on. What should be the number? What should be the actual age that we can define a delayed puberty? Again, I use 14 plus 2. Actually, it's about 1 to 2, right? So that's why I said about 14 to 15 years. Sorry, my math is a little complicated here. It's supposed to be like about 0.5, right? So you get about 14 to 15 years. So these are the numbers that you may want to remember, right? I hate remembering number, but this is some of the numbers that I start trying to remember, right? Remember, when we talk about growth, you have to understand, you have to remember the growth velocity during childhood, 4 to 5 centimeters per year. Below that, it's considered abnormal. Now for puberty, these numbers you might want to have in the back of your mind when you see a patient, right? Now, there's one more classification. If your pubertal development is not completed by 5 years, it's also considered a delayed puberty. Okay, remember, from start to finish within 5 years. So if you see a 16-year-old girl who has developed her breast since 10 years old, but hasn't reached menarche yet, right? That's also considered delayed puberty. We're gonna be going over cases during our academic half day, and you're gonna see some examples. Now, another important aspect is pubertal staging, right? It's part of physical exam. You'll see that many of you guys, when you see children with precocious puberty, first thing you do is order a bone age. I think the resident have passed, those who have passed through endocrine rotation, I stress this many, many times. Bone age is not a diagnostic tool for precocious puberty, right? Or delayed puberty. It's just a supportive evidence, right? You diagnose precocious or delayed puberty by history and physical exam alone, right? It's the definition whether that patient has precocious puberty or have delayed puberty. You don't need a bone age, right? It's very, very, very common. When I see referral, they always come with bone age. And once you don't have a good history of physical exam, bone age can complicate your case even further. Having a normal bone age doesn't rule out precocious puberty, okay? So the first sign of puberty that is caused by HPG axis, remember, it's a central puberty, so it's mediated through gonadotropin, right? So the first sign is testicular enlargement, right? Because gonadotropin binds to the receptor in testes and enlarges the testes. Now, we can't measure the ovary size. So the first sign of girl, puberty in girl is breast development, right? Because we look at the estrogen effect after ovaries have been stimulated by FSH and LH. Now, so this is a diagram of the Tanner staging, right? So very easy to remember. We remember Tanner 2 and Tanner 5. Okay, so Tanner 2, you start to feel small amount of breast tissue under the nipple, right? Under the, it doesn't expand across areola, right? Number 5 is female breast, right? Tanner 3 is when that breast tissue expand past areola and you start to see breast contour. That's Tanner 3. Tanner 4, the picture is not quite clear, but by definition is when you start have secondary mounding, right? Sometimes it's very difficult to distinguish with Tanner 3 and Tanner 4, right? But as long as you can distinguish between Tanner 1 and Tanner 2, right? That's gonna help you diagnose precocious puberty, right? Because by definition, anytime a girl has breast development before 8 years old, that's considered precocious puberty. Now, for boys, it's a little more complicated because you have to measure testicular volume, right? So how do I remember? Just remember, Tanner 2 is when your testis volume is above 4 cc, right? It requires some practice. So when you pass through endocrine rotation, we're going to be teaching you again how to do a Tanner staging in details because we really need to have you master the technique because it's so important when you go on and practice, right? So the adult size of testicular volume is 25 cc, right? But what is more important is that you can determine whether that boy has entered central puberty or not. How do you do that? By examining testicular volume, right? Anytime it's above 4 cc's, it's considered that this is a central sign, central HPG axis activation, right? So once you get to Tanner 3, right? Remember, testosterone being produced in higher amount, so you start seeing other signs such as penile enlargement, right? So that comes in Tanner 3 and 4. Now, we always talked about the Tanner staging of pubic hair. Why do we do this? Because it also can help us distinguish whether this is a central cause or peripheral cause, right? So whether this belongs to the HPG axis or not, right? So if you only see pubic hair development in a girl, that's not central puberty, right? It comes from adrenal, and we're going to be talking more about this during the AHD about premature adrenarche, right? Because it comes from an adrenal gland. Now, in boys, if you only see pubic hair development, it's also very unlikely that this is going to be a signs of central puberty, right? Remember, central puberty stimulates testosterone production. You can have pubic hair, but if you only see pubic hair alone, it's not mediated by the HPG axis, right? The other sign that you're always going to have to determine is testicular enlargement. If you have both testicular enlargement and pubic hair, yes, this could be a sign of central puberty, right? And Tanner stage 5 is an adult pattern. Tanner 1 is 0, right? Tanner 3 is when you cover mons pubis, right? Tanner 4 is expand past mons pubis, and Tanner 5 is when it reached the medial aspect of the thigh, right? So remember, we do it together, you know, either breast pubic hair or testes and pubic hair, right? Because if anytime I see that for example, if I see a 10-year-old boy with Tanner 3 pubic hair, right, with penile enlargement, but prepubertal size of testes, that suggests a peripheral cause, especially a tumor. Okay, so what do we do when you see a patient with concerns of pubertal problem? Okay, so back to the basic, you take history. Onset is very, very important. For example, if you see an 8-year-old girl who has 10 or 3 breasts, you know it doesn't develop just the past couple of months. It could take a year or 2 years, right? So that means this onset is way before 8 years, right? You do family history, because many times you're going to see that there is a positive family history, right? And again, go through everything, drugs, surgery, past history, detailed history is very important, because again, it determines whether, this patient has truly a pubertal problem or not. You want to look at the growth chart. Is there any growth acceleration, right? A rapid growth could be a sign that this is a rapidly progressing type of puberty. Now, you want to do detailed physical exam, especially Tanner staging, right? Again, if you see the signs of androgen, right? Your boys have pubic hair, axillary hair without testicular enlargement, this suggests a peripheral cause, right? Again, on girls, if you only see signs of androgen, just pubic hair, axillary hair without breast development, this is not HPG axis activation. And then you need to send some laboratory tests. This is when you may consider bone age, right? See, I rarely talk about bone age when I talk about growth and puberty, because to me, bone age is not a diagnostic tool, it's a supportive evidence. Right. So when we talked about causes of delayed puberty, I may have mentioned already central versus peripheral, right? So we're going to start with delayed puberty, right? Remember, if it's a problem at the gonad, we call that a primary cause, right? How do we distinguish? We're going to distinguish by laboratory. You're going to see a very elevated FSH and LH, right? Remember, there's a problem with the gonads. Gonads cannot secrete sex steroids. There's a positive feedback loop to stimulate gonadotropin release, right? Now, a secondary causes, we unit this together, hypothalamus and pituitary. We usually don't distinguish between hypothalamic cause or pituitary cause. We call it together a secondary cause. We call it central, right? So this is central, this is peripheral, right? So you're gonna find in laboratory tests that gonadotropins are low to normal, right? So it's not, you don't, even though you have a positive feedback loop, because the problem is at the hypothalamic pituitary unit, you don't have an elevated gonadotropin. We're going to be seeing that during our case discussion during academic half day. So right now, just think of this, and then we'll come back again during the session, right? Now, precocious puberty is the reverse, right? Because we know that majority of precocious puberty is a central precocious puberty, okay? If you find that, if you suspect a peripheral cause, it's more of an urgent issue, because that usually means a tumor or something that is not mediated by central lesion, right? Peripheral causes, again, it's independent of gonadotropin. It's not as common, right? What is more common is the central precocious puberty, right? It's driven by gonadotropin, FSH, and LH. So majority of central precocious puberty is idiopathic, right? So you don't find a cause, a real reason why a patient has a precocious puberty. We believe that, well, there have been discovered some, mutation in some of those genes that control puberty. Well, we believe that whatever reason, the that problem caused a premature firing of GnRH neuron, right? So the GnRH neuron fires GnRH prematurely, right? So I'm just going to give you an overview of etiologies. As remember, this is going to be some clues to your quiz. So for precocious puberty, right? Remember, we divided into central and peripheral, right? So central is the most common cause for precocious puberty. Very, very few instant that you're gonna find a peripheral cause. So what's the most common cause? Idiopathic. We don't know why. There's no brain lesion, even if we do an MRI, right? It's most common cause of precocious puberty. Central precocious puberty in girl is idiopathic, right? Or you could have a central lesion, right? This is the reason why when we prove that somebody has a central precocious puberty, we often get an MRI, right? Remember, we don't start by MRI, we don't start by imaging, right? Without taking history, physical exam, and some basic laboratory tests, right? I've seen it many times that a patient come with already MRI or some kind of like scan or ultrasound, right? It's not very useful because if you do a sonogram of ovaries in young children, you're going to see a lot of follicles. It doesn't mean that that patient has a hormone secreting dominant follicles, right? So central lesion, right? Hypothalamic hematoma. It's a benign hypothalamic tumor, right? So in hematoma, it's filled with GnRH neurons, okay? Or you can have a brain tumor, which is quite interesting, right? You would think of a brain tumor as a destructive lesion, but what happened is it disinhibit the HPG axis. Remember, HPG axis has to be suppressed, right, before you start puberty, right, during quiescent period, right? But brain tumor disrupt that disinhibition circuit, right? So that causes HPG axis to activate prematurely. I've seen in some cerebral palsy patients, right? It is probably the same explanation as disinhibition of HPG axis. Now, when we, I think my slides have been a little bit, sorry for this. Okay, I think my slides have, I deleted my slide by accident. Now, a peripheral cause, right? The peripheral cause, when you talked about peripheral causes, it's at the ovaries or the gonad or the testes. So what's the most likely cause? Is a tumor, right? So tumor secreting hormones, right? From either testes, for example, in testes are called Leydig cell tumor, or in ovaries is granulosa cell tumor, okay? Now, there's one genetic syndrome that I'm gonna be asking in the quiz, McCune-Albright syndrome, right? So what is McCune-Albright syndrome? So McCune-Albright syndrome is a genetic condition caused by a mutation of GNAS gene, which encodes G protein alpha subunit, right? GNAS gene. So what does it do? It's an activating mutation. So the receptor can be activated even without gonadotropin, right? So what do? It causes an activation of G protein that is associated with many receptors, one of them being gonadotropin receptor, right? So you stimulate the gonad to secrete testosterone or estradiol without needing the FSH and LH. So it's considered a peripheral cause, right? So you're gonna go read before the academic half day about what is McCune-Albright. And a little clue here, it's not germline mutation, it's a somatic mutation, right? It's gonna come out in the quiz. Okay, for delayed puberty, remember, there's a primary cause, it's a gonadal lesion, right? We have a fancy name, call it hypergonadotropic hypogonadism, right? Sounds very confusing. Hypogonadism, right? Meaning the gonads are not functioning properly. Hypergonadotropic, I mean, it's elevated FSH and LH. Remember the feedback loop, right? The problem is at the gonad. So it has a positive feedback loop for an elevated hypergonadotropic, which is elevation of gonadotropins. Gonadotropins equal FSH and LH combined, right? So you have genetic causes. Remember Turner, it comes back again because Turner, remember you're missing X, the ovaries do not form, right? In Turner, ovaries are street gonads, right? So that's why when you do an FSH, LH level in Turner syndrome, it's extremely elevated, right? Klinefelter comes back, right? So Klinefelter, you're gonna go back and review what is features of Klinefelter, right? Remember, it's an extra X chromosome. It's 47XXY. Now, they found many, many variants of Klinefelter. You can have 48XXXY, right? You can have 49XXXXY, or you can have also XXYY. So many, many variants of Klinefelter, right? But it also, in a classic case, Klinefelter, an extra X chromosome actually cause a very abnormal testes formation. And I'm going to be asking you in the quiz about a degenerative change of the testes. I want you to go and look that up. What is the pathognomonic degenerative change that you see in the testes of patients with Klinefelter, right? Now, toxic substance, right? Very common in pediatric is chemotherapy. A well-known is cyclophosphamide, very toxic to ovaries. Or you can have a radiation injury to the gonad. Now, secondary cause, this is a central lesion. I'm going to be reiterating again during the lecture, primary, secondary, peripheral, central. Sometimes I use it interchangeably, but remember, secondary cause refers to the central lesion, right? So we have a fancy name, hypogonadotropic hypogonadism. Remember, the gonads are not working. Why? Because the lack of gonadotropin. So it's hypogonadotropic hypogonadism, right? So you think about central lesion, right? So brain tumor, radiation, right? Injury to pituitary, or chronic diseases. So classically, when you see delayed puberty in chronic diseases, such as kids with chronic liver disease, when they don't develop any signs of puberty, we often think of a central lesion. Central cause is suppression of the HPG axis without having a true brain lesion, right? Anorexia, right? So starvation caused a hypogonadotropic hypogonadism. It's at the suppression of an HPG axis, right? And there's also genetic causes, right? I'm going to be asking during the quiz, Coleman syndrome, okay? So it's actually a combination of anosmia, you can't smell, and a delayed puberty, which is a central type of delayed puberty. So it's caused by a gene called CAL1 gene that encodes anosmin gene, right? So anosmin is important for the migration of gonadotropin cells, right, into the pituitary gland. It originates from the same cell's origin, right, in a nasal olfactory bulb, right? So that's why it impairs the sense of smell and also the lack of gonadotropin, gonadotrope, right? It's not gonadotropin, it's a gonadotropes, right? Cells that secrete gonadotropin, right? Also Prader-Willi, it comes back again. Remember, it's Prader-Willi-Lapart syndrome, right? 3 physicians describe Prader-Willi. So it's a central cause, right? Why? Because we still don't know why, but for some reason, many patients with Prader-Willi, they have a hypogonadotropic hypogonadism caused by some unknown cause. So this is an overview of puberty and some principles that I'd like you to watch this before you go into the lecture. Once you have these basic principles, it will be easier when we talk about cases. So I'm going to be focusing more on cases and board style questions during the academic half day. And the end, we'll have a quiz.